right. Good morning, brothers and sisters.
Good morning.
All right. As the future Dr. Quarles was explaining, my name is Milo Dodson. First and foremost, I think I would be remiss if I didn't acknowledge my position still as a trainee. So I am finishing my PhD. I'll be done in July with that after internship. It's a pleasure to be here with you all. It's a pleasure to be here with the panel. As introductions, on my immediate left is Dr. Michael Lindsay, who is an associate professor at the Silver School of Social Work at NYU. His research focuses on child and adolescent mental health services. To his left is Terry Williams, who is a licensed clinical therapist out of New York and an advocate for change and empowerment to destigmatize mental health in the African American community. To her left is Dr. Lonnie Snowden, who is professor of the Graduate School in Health Policy and Management program in the School of Public Health at UC Berkeley, the other UC school up there. His research focuses on mental health and other health services disparities, actually in access and quality of care, and also on understanding disparities from social and health policy and treatment perspectives. And to round us out, Dr. Daryl Hudson at Washington University in St. Louis, whose research focuses and is dedicated to the study and elimination of racial, ethnic, and socioeconomic disparities in health. So if you'll join me in giving our panelists a round of applause. So as a general framework, we're going to be focusing and kind of taking three different areas here. So we're going to be talking more about diagnosing the problem, what are the contributing factors, what are the unique challenges to talking about mental health in the Black community. Then we'll be looking more specifically at the contributing factors, more of the historical, the traditional, systemic influences there. And then rounding us out, hopefully we'll be able to address some of the next steps, where to go from here, some of the research that's still needed. So to get us started, maybe not necessarily in any specific order, but just jumping into the importance of this conversation. Why is this relevant? What are we hoping to gain from this panel today?
I think that it's very important that we're actually having this conversation. I think mental health is like the 10,000-pound elephant in the room that we don't always talk about, particularly in the Black community. And what we find from prevalence rates in terms of those who are using services, particularly from my context of studying child and adolescent mental health services use, is that Black youth underutilize treatment the most, particularly Black youth who have mood disorders. And so it's relevant that we have this conversation because we know that untreated mental illness leads to other public health problems like early sexual experimentation, substance abuse, school dropout, certainly suicide, which is the rate is rising among Black youth, particularly adolescent Black males. And so it's very, very important that we have this conversation. I thank you all for really having the foresight to, have such a conversation.
Are we going down the line?
Sure.
Okay. I'm here to get to know you all. I wanted to meet you all. And I know that the intended messages was about mental health in the Black community, but I really wanted to direct my remarks to you all, because I want to know how you all are doing. I'm speaking the name of a brother who died by suicide 2 or 3 weeks ago, Stephen Rose. Do any of you know him? Did any of you know him? What did? Okay. So this is a brother that comes from a well-to-do family and died by suicide about 3 weeks ago. And so I know we're here to talk about the community at large, and that's all well and good, but I want to know who you are, how you are doing. And I just would like to just lead with this question. How many of you have seen a therapist or are seeing one, by a show of hands? And I'm raising my hand. Okay, that's pretty good. All right. All of us in this room have inherited the unresolved pain, wounds, trauma, and scars of our parents. And the reality is that we are all of what they were or could not be. And so I think it's important to really get a handle on what you're doing, how you're doing when you meet somebody. Do you lead with your credentials, or do you share a little bit of your heart, who you really are? And I was very struck by Nathan was the person that I spoke to. And I just asked him because I just really wanted to know who he was. And I was surprised at his answer. I just said, "Who are you?" I just asked him. And I was very, very surprised with his answer because it was candid. And I won't go into all the details, but I just want to just acknowledge the fact that you did that. I was like, whoa, I didn't ask for all that. No, but it I know you can't take me anywhere. But but I just wanted to just really ask you, how are you doing, And that I want you to take the time out to really get to know who you are, to visit your past, because it's everything. I'm someone who suffered terribly from depression. What I know is that when you go through the fire and you come out on the other side, that's when you find out what it is that you're called to do. And so I ended up writing this book called Black Pain. It just looks like we're not hurting. It has been credited with really putting the discussion out in the forefront, because I'm a very simple person. I'm a very silly person. I'm a very upfront person. And the thought of somebody being alone, feeling alone because they think they're the only one, because they're fooled by the mask that every one of us wears. We have one for every different occasion. That's what I hope today will be, an opportunity to start with you, and then let's talk about how we can get to the rest of the community, because if you're not well, then nothing else is.
Okay, thank you. Yeah, the struggle with depression, for example, is very personal and can be very devastating, and it can be treated.
Right.
That I want to talk a little bit more about later. But in addition, it's a societal issue, perhaps especially so for African American population. So it turns out that the World Health Organization looks at the burden of disease for various countries. That is, how much is individual functioning and societal functioning compromised by various diseases? How much does this disease or that disease get in the way of development? And the number 2 disorder is depression worldwide. So there's a lot of it out there. It's very consequential, and there's a lot of it in African American communities that's not recognized and not treated, or not treated adequately. And I just want to point out that the Affordable Care Act really provides us with a wonderful opportunity, I think, to reach out and to begin to treat, especially African American people, with to get people into treatment and to provide them with effective treatments through the expansion of Medicaid, which some states have taken up and others haven't, through subsidies to people who up to 40% of poverty, through more monitoring of disparities in access and quality in private plans as well as in public systems. And all of this builds on parity. So now mental health care must be provided in a way that's comparable to, without artificial restrictions, limitations, co-payments and such, in a way that's comparable to physical health services that are similar. So I think all of this suggests that we're now in a position where we can really reach out and try to encourage more African Americans to get necessary treatment and to reduce rates of untreated mental illness.
Good morning, everyone, and thank you for being here. I guess I would think about 3 things that I think are important about mental health. Some were already stated by panelists. How many people know what disparities are? I've heard that terminology before. Disparities. Oh, maybe right. Can you guys hear me?
Raise your mic. Clip it to that.
Oh. My microphone fell off. I didn't realize it. How many people have heard of disparities before? So a disparity is more or less a difference in health that is plausibly avoidable, oftentimes related to a policy or practice, and it usually affects people who are already vulnerable. It makes them more vulnerable in respect to their health. Interestingly enough, as a disparities researcher, when we look at mental health, I'm sure you all know this, when we look at our most common mental health disorders, like depression and anxiety, blacks actually have lower rates of depression and anxiety than whites. And just about every large-scale national psychiatric epidemiologic study we've ever conducted in the United States. So that's one thing that's notable. And I think we can think about a lot of different reasons why that might be. The second thing I would say is that mental health is health. I appreciate what Aaron said to start off and thinking about how we're trained. Mental health is health, and I think that more and more we see parity, we hear that word and that terminology. I think that's important. Third thing that I would think that would be important for this audience to think about is something called costs of upward social mobility. And so that's something that I think about, something I studied in my dissertation, is the idea that we're all on this upward trajectory, especially in this room. People are very interested in upward mobility. People have come to this country. They believe in the American dream. Folks have sacrificed for them to be here, and you pay incredible costs. So thinking about how many people in this room are from this area. I would venture to guess that many of you are from far, far away. So if something happens, real life happens outside of these walls, right? You're far away from your social support network. So that's a cost of upward mobility. And then thinking about where we move into and being integration pioneers, maybe professionally, maybe residentially. Oftentimes we're the only person of color, say, on faculty or in a profession. So that means that we're more likely to encounter racial discrimination as well. And you can see differences in who gets promoted, how people are compensated, and things like that. And I think that's a unique source of stress, particularly for upwardly mobile African Americans. So those are three things I can think of that are important.
Excellent. I think to get us started, I don't know about you all, panelists and audience included, but I was kind of moved by the show of hands, not necessarily the fact that everyone in the room, or a lot of people in the room, were raising their hands to acknowledge that they had, sought services before. But I think the idea of being open about that was particularly moving to me. I know, at least at UC Irvine, at Illinois, that's not something that you typically see, a room full of people being able to acknowledge that. So I think that was really moving. And I think translating and transferring that to the first question here, historically we've seen a lot of different unethical practices. So the syphilis study of Tuskegee from 32 to 72. We see even in one of the more popular quote unquote, personality studies with the MMPI-2, African Americans, Black Americans are notably higher in some of the subscales. So I think first question here, what are some of the historical and more like the systemic, even like the diagnosable influences that have dissuaded African Americans and people in the Black community to seek services in the first place?
Well, I'd like to just say, it's a stigma. It's a sign of, quote unquote, a sign of weakness, when in fact it's a great sign of strength to recognize that you need help. There's not anybody on the planet who doesn't. And we're nothing without our mental and emotional health. You can climb the highest of heights and still, all may not be well. So I did want to say that, and I also wanted to just mention that, because we were talking about this earlier, just that at greatest risk, I think, are young Black men and educated Black men. I think that they're at greatest risk. For one, particularly if one is a dark-skinned Black man, you're more intimidating to other people. There is, and I'm not just talking out of my, would any of you all agree with that? Yes. And so it's something that you walk through every day. And so I think that those who are among the most educated of us and the ones who have nothing are at greater risk, and they're the ones who are least likely to get help. So I just wanted to just mention that as an FYI, as part of the conversation.
I think that conceptualizations of help seeking and what it means to ask for help in our community is also something that we need to look at. So for example, there's a rich tradition in our community about not airing your dirty laundry in public, don't say what's happening in the family outside of this house. And so folks have those sort of conceptualizations as it relates to going and talking to a therapist because they feel like they may be airing their dirty laundry. And so, you know, with the work that I've done in terms of research with kids and their families, sometimes kids are very reluctant to talk about what's going on because they've gotten those messages, you know, from the family. I think when it comes to men, again, in terms of help-seeking conceptualizations, as Terry mentioned, to ask for help, to acknowledge any sort of vulnerability is a sign of weakness. You know, historically, that, you know, we don't honor those who are actually vulnerable and say, you know what, I need help. We think that, you know, again, it's a sign of weakness. And interestingly, in one of my studies, we are recruiting a kid recently who was very depressed and very interested in getting, you know, into our project, but his mother was telling him, you need to deal with those problems on your own. You don't, you know, I'm training, she was telling me, I'm raising my son to be strong, to be tough, and acknowledging that, you know, he has depression and he's weak and he's crying all the time is something that, you know, I want to steer him away from. So you see those, again, those conceptualizations around, you know, being vulnerable and what it means to ask for help is very much rich in terms of the tradition in our community. And I think the other thing is that certainly we're spiritual folks, right? And we believe in going to church and we pray and that sort of thing. And sometimes what has happened is that we seek those sources in absence of going to a professional counselor for help. And I'm not saying that we should not do that. We should do it in concert, right? There should be sort of parallel processes. But I think what happens is some folks are perhaps steered away from mental health professionals because, you know, the message is, you know, God will take care of it, pray about it. Right. And then there's, you know, been, you know, sort of a legacy of how mental illness is defined in spiritual communities. You know, that it means that you're demonic, you have a demon or that sort of thing. And so I think those kinds of issues are really laden in our community and affects help seeking. Absolutely.
Yeah. And I wanted to just add to that. I remember very clearly, because you're right, we would say, take it to the Lord in prayer. I always say, and I speak at a lot of churches, that it was my God who led me to the right psychiatrist. That's what I know. And so, you know, I'm just saying.
Yeah, sure. Yeah.
Amen.
Go ahead.
No, go ahead.
I was just going to say, I think it's especially important to have this conversation now because so there'll be millions of black people with a mental health benefit, but it will do no good.
Yes.
That's right.
Unless some of the issues that have been raised here are addressed.
Yes.
I'm sorry.
Yeah.
I'm not going to take up everything
No,
all the time.
absolutely.
But I just want to say that I think it's important for us to share our stories with one another. That's what will, because I meet you and I think of you one way, and then you tell me your story and it says, oh, that person is human and vulnerable just like I am. So that's really the key, and that's what I've been trying to do across the country wherever I speak, get up and ask people to, I'll say something. Sometimes when I recount my depression, the tears come to me because it was a really horrific experience. But it's the sharing of your story with someone else that will help us to begin to let people know that they're not standing on that ledge by themselves.
I think everyone covered pretty well. The only thing I would think about adding, can you guys hear me, is how people cope with stress. There's things that we can admit to. So if I ask people, if you have a really bad day, say yesterday was Friday, had a bad exam, didn't get a job, et cetera, et cetera. If you were being real, how many people would say, well, I went and got a drink? A few people. Or I ate a high-calorie, high-fat meal that made me feel really good. And people, we're all human animals. I mean, we're animals. We figure out what works best for us when we encounter social stress. And some of those things that we cope with can be protective to us psychologically, but can harm our physical health. So if you look at, like I mentioned, disparities in mental health that seemingly don't exist, look at any chronic disease, diabetes, heart disease, et cetera, all these things that are linked to lifestyle. and you can see that we have much higher rates compared to whites. So I think that's something to think about, is how we cope with stress and what's socially acceptable in our networks. So if you're a big man on campus and you say, well, I'm cool and I just have sex with all these women, right? That can be deemed as a positive thing. But if you said, well, to your point earlier, Malo, if you said, well, I went to see a therapist, what would be the difference in reception between those two people? And so I think thinking about how we cope with things, how we accept things in our network is very important.
Yeah, and the reality is we will do anything to not feel the real pain that we're in. We self-medicate with promiscuous, unprotected sex, shopping when we don't have any money, gambling. You know, I touched a chord there on that when I saw a couple of people shopping when you don't have no money. That's what and you know, those are the things that we'll do to not feel the real pain that we're actually in. You know, think about what your vices are, just anything to not feel the real pain that we're in.
Yeah, absolutely. I think we're talking about more preventative approaches. We're talking about non-traditional, quote-unquote, ways of getting out of the Eurocentric one-on-one individual therapy and talking about outreach efforts and whatnot as well. We can get to that towards the end and next steps. Next question I wanted us to start thinking about was over-pathologizing Black or African-American clients and some of the systemic and some of the institutional influences that has within therapy. So where does that come from? What are some of the things that we see being over-pathologized, and maybe some of the contributing factors there?
Well, I think about this book called The Protest Psychosis by Jonathan Metzl. He's a psychiatrist at Mosaic University, Michigan, now Vanderbilt University. And he talks about how some of the symptoms of schizophrenia, for instance, so feeling like you're being followed or feeling like people are paying attention to you. Well, but like we mentioned earlier, for African American men, even in 2014, we think about, you know, Oscar Grant and Fruitvale Station. We think about, you know, all these brothers who've been monitored, surveilled, and lost their lives. So to some degree, yeah, I'm paying attention to what's going on around me. And if I talk to somebody about that, I might say, well, it does feel like people are watching me. It's certainly being a person of color in a position where there's not a lot of me around, I certainly feel like I'm being watched. So I think that's something that could be related to overdiagnosis of, say, schizophrenia versus depression in African American men.
You know, I have another perspective on this question. And again, it comes from the work that I do, the research that I do in school-based mental health services. One of the things that we find is that, as a general matter, most kids who end up in mental health treatment have what we frame as an externalizing disorder. So these are kids who are ADHD or conduct disorder. Any of the externalizing behavioral disorders are likely to sort of get you into treatment, and that's for all kids. Certainly that is the case for Black youth, right? But then there are some nationally representative studies that suggest that Black youth are under-identified with respect to mood disorders. Mm-hmm. And so we know that one of the symptoms of depression is irritability. And so, for example, in the work that I do on depression with Black youth, almost, you know, anywhere from 90 to 100% of them have some form of irritability. So they're angry or they're temperamental and they may explode on someone. And so, unfortunately, what happens to Black youth is that those behaviors get interpreted as sort of externalizing issues, and then what happens is those kids get referred to juvenile justice, or there may be some child welfare involvement, depending upon the nature of the behaviors. But I think that one of the issues is that we don't recognize mood disorders like depression or anxiety in Black youth, and that's problematic. And so, you know, one of the things that we can do is better sort of educate family members, teachers, those who work with Black youth around sort of being able to detect those symptoms so that we can get kids appropriately treated. And the reality also is that most kids who have a disorder, I think, again, nationally representative studies suggest that if you have a disorder, about 50% of kids have multiple disorders. So there's a lot of comorbidity, and so you might see a mood disorder along with, conduct disorder or something else. So, it's important to kind of differentially be able to diagnose and to indicate what exactly is going on. Okay. And that's been problematic.
I think another issue is the frequency of violence in our communities, where people, and young people, adults, whatever, are witnessing someone who's shot and killed right in front of them, and then they get up and go to work or school the next day like they didn't just see that.
Wow.
You know what I'm saying?
Yeah.
And in terms of a kid who's in school who becomes disruptive and is just not being able to function properly because of what they just saw, that's when we oftentimes get labeled with ADD, ADHD, smart as a whip, just can't forget what they just saw. So, that right there, once they are labeled, that's the first step toward prison and the grave. And I think that, PTSD is a major, major, major issue in our communities, even perhaps if not more than in war. And it's something that we really, really do need to address and talk about and see that people get help. And I also think there's something to be said for the training of mental health professionals, and that is to have a sense of what it's like to be a person of color in the community, so that you understand. Like, I work with a number of young men, narrowed down to 2, who are members of the Bloods. They are not active, they denounce violence. One in particular I take with me a lot of times when I go speaking, and he is just the truth. He speaks about domestic violence when he was growing up and how he could not respond. His mother she didn't want the kids to witness it, but she would lock the door when her husband came home to beat her, so that they wouldn't be, they would be impacted. But so I just wanted to say something about that PTSD is no joke. And there's a film that just opened yesterday called Frankie and Alice. I don't know how many Halle Berry stars in it. And I just read recently that she's someone who had multiple personalities. The technical word is what is it?
Dissociative disorder.
There you go. Yeah. And so it's what happens when you don't resolve your stuff, that you end up, becoming someone else. Actually, and when you meet, and it's important to know this, that when you meet somebody, if you're in a professional relationship or even, a personal relationship, it just looks like, okay, it's just you and I, Nathan, I'll just keep picking on you because you're the person I talk to. So you and I have a relationship, right? And I come out of my mouth in a very foul way, and you want to say, well, what's wrong with her? You don't ever, there's like 4 or 5 personalities in you, and I got 3 or 4 of me, and when you interact with people, you don't know which one's coming out. So it's important to, did I hit a chord there? Do you have multiple personalities? Oh, okay, all right. And just, and just the anger issues, you couldn't get at the person who violated you. I talked to some students last year, showed them a video, and this young man gets up very courageously, he's 15 years old, and says he stabbed somebody 7 times. He didn't kill him, but it's what he said after that pierced my spirit. He said, and he wasn't even the one I was mad at. Uh-huh. Like, so clear that it was directed towards somebody else.
Yeah. So this is why, working in trying to make headway in mental health and mental illness and treatment and prevention is difficult anyway. Yeah. But it's especially challenging in with African Americans because, sometimes when you see things that might be mental illness, what you're seeing is a legitimate reaction to difficult situations. Mm-hmm. Yeah. Sometimes it's a legitimate reaction that turns into a mental illness, and sometimes it's mental illness. And so how do you sort that out? It's very tricky, and it's especially tricky because of the very difficult conditions under which we so often live. And that's why we need people like the people in this room who really have some awareness of the very special issues that face African Americans.
If I could just piggyback on a point that Terry made, which is interesting, is that the PTSD piece is really, really huge. You know, a lot of the sort of urban stressed communities of color, you know, kids see a lot and face a lot of adversity. And so what's interesting is that, again, this sort of help-seeking conceptualization that prevails in our community is to, you know, tough it out and to, you know, really, you know, sort of move beyond it, move on, and that kind of thing. We had a kid in our study that we engaged in treatment. She is 14 years old. She just completed our program, and she was reluctant to participate in treatment. And the thing she told us was that, you know, therapists get paid to listen to you, and I don't trust, you know, what the therapist is going to do with the information I convey. And so, you know, we encouraged her and her mom to be involved in the program. Reluctantly, they did so. But what was interesting, so this young lady was very, very depressed, suicidal. And in the context of the treatment, she revealed to the therapist that she had been raped 2 times. And her mom didn't even know anything about it. Not a clue. And so this was the first time she had ever told anyone about her rape. And she was raped by a family member. And so, you know, the level of need is just so intense. And this is why we need to connect folks to treatment. We need to be connected to treatment ourselves, because the level of pain is so deep. And we wouldn't have gotten at any of that had we not engaged her around the depressive symptoms and then found out, wow, there's more to this story. And so you know, it's really, really deep in terms of the things that, you know, youth and families are facing.
Yeah. And we haven't named it. I saw there was a 2-year-old who was shot in the leg in a playground in Harlem. And I saw some quotes from her mother the next day, and she was saying that every time now she hears a loud noise or any kind of pop, she like starts crying and just goes like crazy. And I'm saying, so she sees what happens, but she doesn't know that it has a name and it needs to be treated. That little girl needs to be in a room with a coloring book talking to a therapist, you know, playing with a therapist. But those are the things that we don't know, and it's about awareness.
Yeah, and increasing the access and increasing the competencies for treating African American and Black Americans. What are some of the multicultural competencies that you would like to see more ingrained in some of the training programs? And I'm thinking particularly here because at UC Irvine, I'm the only Black therapist. So when I'm trying to go and do outreach in the community, and I'm talking about, well, you have an option to seek treatment and, you know, identify a cultural background for your therapist. And if you want to talk to a Black therapist, well, I'm pretty much it. So trying to, like, no joke. So trying to identify different training regimens, or what do you all wish for to be ingrained in training programs? Because ultimately there aren't as many Black therapists to be able to work with Black clients if we're talking about increasing access here.
Yeah.
You go ahead. You go.
Well, one of the things that I think is important is to really lay out that we have, again, my context is youth. We have interventions, evidence-based interventions that we know work, right? For a number of, I think Lonnie mentioned earlier that depression is treatable, and we have evidence-based treatments for anxiety, depression, the list goes on. And your point is well taken. We have to be able to train therapists to be, you know, sort of culturally competent. And when I talk to clinicians and do trainings, one of the things that I lay out to begin with is that you have to be able to have authentic engagement, right? So it doesn't mean that you're here to teach folks, you know, about their lives and what they should be doing. They're not there to teach you about their lives. You know, the authenticity should be about, you know, really, really meeting them where they are, not presuming that because they're from a certain community that they have certain belief systems and that sort of thing, but really checking yourself your biases at the door and being able to sort of authentically have that moment with a youth or their family or an adult who is in treatment. And I think that it's a huge issue, and one of the things that we have to be cognizant of in training programs is to really sort of prepare people to positively engage with youth and families. And let me just make this last point and I'll stop. You know, I think that we have to be careful too about the whole ethnic or racial matching of therapist and client, because you can have an African American or black therapist who is working with a black youth or their family, and they can do irreparable harm to that family if they're not authentically engaging with them. And a white therapist can have much more productivity if they're authentically engaged. And then my research with youth and their families bears us out that race doesn't matter as much to them. They want someone who's going to believe in them, understand where they're coming from, and have that authentic, sort of interaction with them. So.
I agree with you, and I was going to mention that with the two young men who are Bloods that I work with. I have a good friend who's a white guy who's an internationally renowned trauma expert, and I decided to bring the three of them together. And I'm thinking that we'll be there for like 2 hours, and we were there for like 4.5 hours, and they talked and they wept and they talked and they wept, just releasing so much of what their childhoods were about. And you said it in a nicer way, but I was going to say sometimes we could have bougie Negroes who are therapists and can't identify with it. I'm just saying.
I hear you.
Right. That's brilliant.
I'm these days pretty much a health policy, public health kind of person, but I was trained as a clinical psychologist, which often surprises people, including me sometimes. But but a concept that gets at some of this that I really don't think we do enough with is therapeutic alliance.
Yeah.
So, for lots of kinds of work in general health, as well as, but especially in mental health, it's important to build a certain kind of relationship where there's genuineness, intimacy, people feel that they're understood, you're both on the same side. And we actually know a little bit about those relationships, what the therapeutic alliance ought to look like, and how some people can assess to some extent how some people do a better job of developing it than others. So I think that's a concept that we really could, that applies a lot and that we could do more with.
From a public health perspective, again, that's my background too. I think about the bias that any clinician walks into a room with. Black, white, it doesn't matter. Everyone sees our world, everyone's expected. There's so many norms that are in our society. We have to think about how to train our physicians, our clinicians, et cetera, and how to acknowledge those stereotypes, those things that these preconceived notions in general before they walk into the examination room, because those things do have an effect on the interaction. The second thing I would think about, because most people who are diagnosed with, say, depression are seen in a medical interaction, so they'll be seeing guys like you. So they might be seeing an internist or endocrinologist or something like that, and they'll pick up something, maybe they'll get screened. So I think that it's really difficult, particularly when outside of a youth context, when people are getting older and they're starting to develop chronic diseases, diseases that are difficult to manage, and there's competing demands for physicians. So physicians may have all the best intentions. I'm sure our medical professionals in the room have seen this. When you've got a lot of things going on at the same time, multiple comorbidities, you have social and economic issues, and you might have a mental health problem. How do you, in a very short, limited clinical interaction, how do you get through all of that in 5 to 10 minutes? And that's really difficult.
I think often, and I don't have a problem with this, with many white friends and colleagues, I often find myself explaining to them how we're different, because they need to know. And if they don't know, they don't know. And I see it as just part of who I am. to do that. I remember when I was working with a corporation some years ago, and whenever it was the day after one of those award shows, I would know that I would have to start off the conversation with why so-and-so rap artist said or did whatever he did. I was always like in a role of explaining, and I think that you should consider just explaining things. I remember one of the things when Arsenio was on the air the first time around, he would, if he knew that a black person or a white person said something that the other wouldn't understand, he would take the initiative to explain that. Do you remember that? Mm-hmm. Yeah, and I just thought that was a really great thing, because that's what we're supposed to do, is we have to do, So I just wanted to share that.
Yeah, absolutely. And I think to your point about, to all your points really about color and racial background, so specifically color is not indicative of consciousness all the time.
That's true.
And I think the question about the training and how we can implement that is for just as much for black therapists as it is for non-black therapists, because you don't want to go into a room thinking, well, this is another black man. I'm a black man, so I know what his experience is going to be like. I think taking the approach of understanding the uniqueness and the lived experiences behind all the cultural identities is really important.
I'm sorry.
Yeah.
I was just going to say that I think humor is a great way to get your point across as you move through life. I mean, I can be with someone, anyone, could be a white person or whatever, and they will say something that's just not cool, just not correct. And I would just say, no, we don't say that now, and then I'll say what they should have said, and then it brings about some laughter, and they understand that was like a no, you just don't say like that, And they laugh, and I'm laughing, and so it's all good.
Right.
I know Tesla can't take me anywhere.
One of the other questions I wanted to get into before we get into kind of next steps and where to go from here is discussing and exploring specifically race-related stress within therapy. I think we've talked about that in various degrees, but really recognizing that that's not just necessarily something that we want to pathologize, but really understand as unique. And I guess in this conversation, unique to the black community. So how might we explore in a therapeutic setting race-related stress, and with the understanding that there's been studies that show if you have a developed and you really embrace your racial identity, that more times than not you're going to have an overall higher level of well-being and mental health. So again, the question being, how do we explore race-related stress within the therapeutic setting when working with black clients?
Yeah, I think that, I'll just start off. I think that you have to, be prepared to have those conversations, particularly around what those stressors mean. And a lot of times, some of it gets interpreted as sort of financial stress or occupational stress or what have you. But I think you have to sort of be receptive and open to having, honest dialogue about what race means and how it is being interpreted in the context of that particular situation. In my work, most of the kids that we work with live in homogeneous communities racially and ethnically. So, most of the stressors that families bring in are really about socioeconomic stress. But then, as they kind of think through like the challenges with respect to resources in their communities, they do sort of talk about how their community may get, slighted as opposed to other communities and that sort of thing. And so, we have those conversations in ways that are, I think, clinically meaningful in terms of helping them to cope and to, sort of move ahead with those particular stressors.
Well, I don't think I'm that clinician, so I have to think about this from a public health perspective. So when I entered this field and thinking about mental health, I was really frustrated with the one-on-one interaction. So I was wanting to look beyond and think about, like people in this room interested in policy, what are some of the things we can do from a policy perspective to address that? I want to go to next steps, but thinking about those social economic inequalities that are related to race. So people use those things interchangeably a lot of times, and that's the same thing. But there's unique stressors that African Americans face, even people who are upwardly mobile. So there's a lack of wealth within the African American community, right? So even for people who have the same amount of income, people who are highly educated, have vastly different wealth differences between the two of them. So what does that mean for them in their life trajectory and the stresses they're going to have? So it's not necessarily a race-based stressor, but it's something that is certainly influenced by policies and practices, racial segregation that still exist in the United States. And thinking about where people get to go to send their kids to school and things like that. Can you afford to buy into a particular neighborhood that has better schools? If you don't have the wealth, you can't get into that school district. So I think those are some of the unique stressors that can to Michael's point, sometimes they manifest as socioeconomic, but they're also race-based.
I was going to say that well, one thing that I thought of, my mother's physician who specializes in geriatrics. I just decided to give her a copy of Black Pain, and she wrote me a note and said that she thought that it should be in med schools, that school, people, to prepare them so that you understand what population you're likely to be dealing with. But I just think that wherever you can, it's your responsibility to clarify situations. You have to, it's like you sometimes say, well, now, I can say this, I'll say this to a white friend or colleague, I can say this, but you can't say that and get away with that. You know what I'm saying? So it's if you are being true to who you are, and if you just say it in a, just a very, very easy way so that they understand, you're helping them. That's why you're in the room. That's part of why you're in the room. You may not think that's part of why you're in the room, but you are there for a reason. The other thing is that I'm drawing, Samson Davis is a brother. Do you all know who he is? He's a physician. He and two other brothers made a pact in New Jersey. That's what their book was called, The Pact. Well, one of them has written an amazing book. I can't remember the name of it. He's in the ER at a Newark hospital, and he talks about what he sees and in terms of the community. But it's something that I think is well worth reading. I just wanted to mention that. How does it feel being moderator? Because you can't talk as much.
Well, you're right. I can't talk as
So I'm
much.
giving you permission.
Oh, thank you for bringing me. I appreciate that. So I think I wanted to just be aware of time. Are we going to be closing? And I will talk a little bit because I appreciate the permission. Are we looking at 40 as opposed to 11:30? Okay. So I will jump in to say I think there are different ways of exploring race, and I think one of the more challenging things for me at Irvine in particular is the idea of colorblindness within the Black community. Not necessarily even from non-Black folks, but with an internal sense, you want to trivialize and minimize the importance of your Blackness because you want to be able to connect with others. Being Black is difficult, so for some people, so why would I want to address that, or why would I want to identify with that? So looking at colorblindness from more of an intragroup perspective opposed to a non-Black perspective. The other thing there is, I think, in newer and younger generations, so the Black men's group at Irvine I just met with Thursday night, and one of the brothers was talking about, well, I don't really care as much about race because it's not as salient to me. Mm-hmm. So really having a discussion about that kind of hurt my heart, to be honest with you. Mm-hmm. And really making sense of what that's like for a new generation where racial identity and racial constructs are a little bit different. So yeah.
Can I?
Yeah, you can ask me questions, though.
Oh.
It's all good.
But I wanted to say something about another way in which we could work on our mental health, and that is the young people that are in your lives, in our lives, we have to tell them the truth. Adults always want to be perfect. They want to be the all-knower, the protector,
Yes.
right?
Yeah.
So in that role, you end up lying to your kids. You pretend that you're fine. But kids are smart as a whip. Because if they work with us, live with us, work with us, go to school with us, they already know we're crazy. There's nothing that you can say that would have them think otherwise. They know that. So I think that we have to work harder toward telling the young people in our lives the truth, that to be unafraid to cry in front of them. I remember somewhere I was speaking about this once, and this woman said that her 3-year-old came up to her. She said, "Mommy, how come we never see you cry?" When the kid says, "Mommy, Daddy, are you okay?" or "What's wrong?" and the adult says, "I'm fine," it's at that point that you are setting the kid up for a lifetime of not being emotionally healthy. You have taught that child how to lie. You have taught that child to second guess their intuition, because they asked you if you were okay because they saw something. And then they realized that this most high person in my life just lied to me. Also, when you lie to them, you're not teaching them, which is your role, you're not teaching them how you get through your tough situations. Okay, your dad and I had an argument. We love each other. We're gonna, we're down for the long haul, whatever it is you want to say, and we will get past this. Or I didn't get that gig that I wanted, so I'm a little bit upset about it, but it's a healthy thing to cry. And sometimes I might talk to a therapist, and sometimes I might be on medication. I might go for a walk. I might exercise. So I want to say that everybody in this room needs to be mindful of interacting with young people in your life. Tell them your story so that they know that they're not standing on the ledge by themselves. And I want to say this because it's the power of a story that you share with someone that can just open things up for them. Both of my parents were abandoned by their fathers. My mother's very bitter, is still. She doesn't even cuss, but she calls him an SOB whenever she does refer to him. I lost a thought. Where was I?
Sharing your story.
Sharing your story. Right, thank you. Thank you.
Euphemism of a SOB.
Thank you. I just want to see if you were listening.
You got you.
My father, as I said, both fathers, if I didn't say, they abandoned their families. But my dad was a very, very sweet, very, very kind man. And one of the things that had a profound impact on me is that when I was growing up, my mother was the more vocal one. Whenever I would ask my father, sometimes it's a little emotional when I think about it. Whenever I would ask him, "Daddy, what do you think about this? What do you think about what I have on? What do you think about this?" He never answered me. He always said nicely, "Ask your mother." The impact of that was I was always searching for a brother to give me an answer, to tell me something, because my daddy didn't. And so I'm sharing that with you because I know I'm not the only one in the room with a history story like that. And so it's when you share your story with someone that you can have a very, very, very profound impact. And everybody in this room has one.
Yeah.
So I just wanted to share that. So then I dealt with that in therapy as well as anger issues. Not like friends, family, and staff didn't know I had anger issues, but I found out in therapy. So I had to run around and apologize to everybody. Because I'm a very kind and thoughtful person, But then there was this other side that would come out sometimes, and ooh.
Yeah. Let me, what that makes me think about is just is prevention, and about how, and something, just to loop back to something we talked about earlier. Lots of times, and I think this is especially true for Black people. As was said, we don't want to talk about these things because it seems weak. We don't want to seem weak. We don't want to seem vulnerable. We don't want to seem weak. And so there needs to be a redefinition of what's strength.
Yes.
So strength is saying, okay, this is going to be hard for me to do, to talk about, but I'm going to do that because I'm a strong person. And something like that, I think, would go a long way.
That's a good point. Anybody have a story?
We would invite you to share. We would
everybody's
invite
got
you to
one. I
share
got
your
one.
story in the Q&A that we will have in about 7 minutes or so. In moving forward, I think the next section to wrap us up before the Q&A and sharing your narratives would be much appreciated. Moving forward to understanding our next steps and future directions, I think what we've been talking about a little bit is this idea of emotional transparency. To break that down a little bit further, the ability to be vulnerable and be comfortable with our vulnerabilities. So in addition to that, we also talked about preventative models, preventative approaches, outreach and such. And I know one of the programs that I've been familiar with is Beats, Rhymes, and Life, actually out of Northern California, where they're taking a evidence-based approach to really address some of the PTSD with the brothers and sisters up in the Bay Area. So in addition to that program, any other prevention models, any other ideas for next steps that you all would like to share?
Yeah. So I can start off by, again, the context of my work in school-based mental health service delivery. So right now we know that schools are the largest provider of mental health services to youth. And the sad and stark reality is that every school does not have a mental health professional
That's right.
in that building. And to me, that's a travesty.
It is. It is.
So right now, there is in the works, and being considered in both houses, a School Mental Health Act. And so what we can do is really lobby and advocate for the passage of that act, which will provide more resources so that every school can have a school-based clinician. You know, and I see that as imperative, particularly in urban and highly stressed communities. You'd be surprised, there's no school mental health professional in that building. And so I think that, and then the other thing is that when we do have professionals, they have to do sort of like blended funding just to support their role in the school. So they're robbing Peter to pay Paul, you know, in terms of, you know, really trying to provide quality and services in the building. So I think that that's a policy initiative that we all can get behind and support.
You know, that's an interesting point because, you know, when you register for school, you have to have a physical, right? So they really should have some kind of mental health aptitude kind of thing for the child and the parent. Because if you know the parent.
Under the Affordable Care Act, mental health screening is paid for kids.
Wow.
So, you know, there again, the structure exists now. It's a question of really taking advantage of it.
That's right. And that's true because under the Affordable Health Care Act, there is supposed to be an expansion of school health centers. And, you know, what I like about that is that part of the sort of initiative in that is that everyone in the building is supposed to have the language, the skills to be able to identify symptoms. Not necessarily to diagnose, but to understand if Michael is exhibiting, you know, an issue that warrants clinical attention. And so I think that that's another important part that I think the Affordable Health Care Act can play.
Did you say that there was a mental health act being?
It's being considered, yeah, School Mental Health Act, yeah.
Where? Like nationally or?
Yeah. So this is at in the Senate and the House.
Know.
Yeah,
I didn't know
yeah,
that.
yeah. The representative that's leading, and I'm blanking on her name right now, is from California. Yeah,
Wow, that's good information.
yeah.
I think an important next step, and this is not sexy, but I think we need, and this is from a research perspective, we need data. We need mental health data. We don't. So I'm based in St. Louis. I recently was part of a team that looked at African American health disparities in the St. Louis region, and I tackled the issue of mental health. And I really couldn't find any data to talk about mental health outside of emergency room visits, which people do go to the emergency room, which I'm sure Lonnie can tell you drives up. It's very expensive to go to ER for mental health issues. But outside of that and some basic depression prevalence data from the state level, I really couldn't say very much about mental health in our region. And I think that would probably be true no matter what major metropolitan area in the United States you're talking about. So people in the providers came to me and they said, well, what can we do to better address the mental health needs in this area? And I said, well, we don't know what the mental health needs in this area are. And we don't have the data to say it. So that's something that we need to do so we can properly allocate resources so we know where we should be doing outreach, how we can get people involved and things like that. So that's what I would say is important for next steps.
Yeah, I just want to come back to the Affordable Care Act. You probably heard me talk about this enough, but there it sits, and there are all these really wonderful opportunities that I hope we can take advantage of and do something about some of the long-standing problems that have stood in the way of African Americans getting needed and effective mental health care. So data, you're right, we don't have enough of the right kind of data. It turns out, I learned this from a woman named Elise Adams, who's a Kaiser Permanente researcher, excellent health services researcher, African American woman. So she's on the private side. Most of my work's on the public side. And there are alliances on the private side of payers, health plans. And one of the first steps they spent an awful lot of time and money trying to take is getting data by race and ethnicity that are believable, that are comparable across plans and that are believable. And so it turns out that they just haven't done a very good job about that over the years. And so doing the kind of basic accounting of where the disparities are in those plans can't really be done without the right kind of data. There are also, and that's just one example, there are a number of provisions, and they're being inspired to do this by the ACA, which requires an accounting of disparities. So, I'm struck again, I just want to come back to this. So there are going to be millions of people, African Americans, who for the first time will have an insurance benefit with mental health and substance abuse coverage. That won't mean anything unless we take some steps like we talked about earlier, where some of the things that keep people from thinking about mental illness as something they might have, and taking the necessary steps to get treatment, and also developing a workforce and systemic structures to support the new people seeking help, to provide them with effective care. This is an opportunity to do that, and I hope we do.
And if I can just add one more point, I think what can also be important is that everyone in this room leaves today with a passion for mental health, to take back to your communities or wherever you go, and really, be passionate about your own mental health and, seeking therapy, because I think much like we go to a health care provider to check in on our physical health every year, I believe that we should also make an appointment to check in with a therapist about our mental health. We ignore that too much. I learned this phrase from a professor in grad school: if you can't talk about something, it's out of control. And so I think that we have to be able to convey messages about the importance of mental health to our loved ones as well. I had a friend just a couple of years ago tragically died. He had a psychotic break, professional, doing well, making good money, he and his wife, 2 kids, but he died. He had a psychotic break. He was shot by the police because he was threatening violence. And one of the things that his wife said to me was that he had a setback at work, and I wish I would have talked to him more when he brought it to me. I basically told him, you get over it, you'll be fine. But he, continued to sulk about it, and ultimately, had this break. And so, we have people in our lives, if we're not struggling ourselves, someone we know is struggling, we have to encourage folks to really get help.
Yeah, absolutely.
Right.
Yeah, before we get into questions, but go ahead.
No, I was just going to say that a very small thing that you can do, but it has a profound impact, is to smile at someone when you're walking down the street, especially in the inner city. Because what we've learned in the inner city is that so many people feel like they don't matter. And sometimes I will smile at a brother who's, coming toward me, and he'll turn around to see who I'm smiling at, because he knows I'm not smiling at him because he doesn't matter. So we have too many people who are walking down the street just knowing that they are irrelevant and that they don't freaking matter. And so with just a smile, you can transform somebody's life, someone's spirit, and I just want to encourage you to do that wherever you go. Be kind to people that you meet.
Absolutely. So now in the next 15, 20 minutes or so, wanted to be able to open the floor to questions. Okay. So I definitely, this brother right here, I think you beat everybody up with the...
Well, the first thing I just wanted to acknowledge. The first thing, I'm a research fellow at Brigham and Women's Hospital, trained in epidemiology, studying psychiatric epidemiology. And I also wanted to acknowledge that even though we have lower prevalence of depression, the chronicity
That's right.
and the functional severity
Yeah.
is much worse in African Americans than it is when compared to whites. And then when you also think about the impacts that it has on chronic illness, if you look at patients with mental illness, and you look at their chronic disease outcomes, they're much worse than they are for people without mental illness. But one of the things that I wanted to ask is going back in terms of next steps and also in terms of the role of our cultural institutions in our community, which play a profound role in bringing everyone together. How can we leverage them to improve our mental health literacy and also as a detection tool to get people to treatment earlier as opposed to later? I personally believe that that's an opportunity that we have to actually improve some of our stigma that we have and also some of our duration of untreated illness that we have in our community. I wonder if there's a systematic way that we can actually leverage our cultural and religious institutions.
Yeah, I'll just say real quick that I know of some work, some folks are doing this work where they're going into churches and training pastors on sort of being able to triage their parishioners into services, particularly for depression. And so I know some folks at Columbia University doing that work, and it's incredible. It's incredible work. So I can, definitely, if anyone is interested, turn you on to those folks.
And while I agree with that, I also think that it's important. And when I do speak at churches, I always ask the pastor if he or she herself says, or if they don't, to say from the pulpit, when I was in my therapist's office.
Wow.
That right there would be very, very significant, because if the preacher is going and you know he or she needs to go, everybody bringing you their problems, and it's no joke trying to, oof. Yep. So I just think that, that's a good place to start, and to share that with young people. I just can't say that enough. Sometimes I will share a revelation that I had in therapy, because it's the gift that keeps on giving, and it will never be normalized if we don't speak about it.
Right.
Oh, right. I'm trying to figure out an approach, a systemic approach. Aaron, you want to?
I'm raising myself up so you can see me.
Okay, well, you are, go right ahead. Just go, yes.
This gentleman keeps talking about the Affordable Care Act and what's available to us. But it seems like I live in a senior handicap building, and I'm also a JFK school alumni. But I see more and more nowadays, because all these institutions have been systematically closed down, and they have a couple of outpatient things going on in Boston. But it's not enough. And if this Affordable Care Act stuff is available, why isn't there something else in place to replace all the institutions that were closed? Because now, all these people are either getting arrested, or they're getting in trouble, or they're getting hurt, physically hurt, and what have you, losing your housing because of their mental illness. And there's so much stuff going on, and there's nothing in place. It seems like they're just just shut everything out, let them go, let them turn them loose, and that's it. And there's like nothing in place for it.
Yeah.
And something has to be done.
Right.
Something has to be done.
So how to actually, one of the problems with the affordability is it's complicated. It's very complex. And by the way, that's not President Obama's fault or his idea. The American healthcare system is very complex. And so just pointing that out as background. So how it applies to any particular situation requires a lot of specialists analyzing that. So people who know about who's eligible for what and how it's going to, and what Affordable Care Act mechanism applies, you need specialists to be able to make those determinations.
I understand that, but if I'm asking you and the rest of the panel, do you know of anything else that is in place or in the pipeline to replace all the institutions, be it inpatient or outpatient or both, to replace what has been taken away? Because they've all been shut down. Well, I can't say all of them, but the majority of them just come and shut down within the past 10 years. Is there anything? And if not, is there something that can come? You guys are the
Yeah, I think that some of it may be, geographic specific or, location specific. And so you bring up a point about, wherever, you hail from. But I know that in some places there is an effort to, put more resources into community health. There is certainly a problem that we see in youth mental health services with respect to kids who have mental illnesses going into higher levels of treatment. So inpatient treatment is very expensive, and so there is a push to put more resources in the community. And so with kids who have mental disorders, there's like home-based services that are being activated. I know in the state of Maryland, I've been involved in an evaluation project to look at an in-home program that's designed to keep kids connected to community-based treatment, and as well as getting support in their homes in lieu of going into more restrictive, more expensive settings. So again, some of it may be, based on where you are and what sort of the climate is around those issues.
I'm saying like inner city areas like Northeast Florida. Northeast Florida inner cities.
Maybe you speak more about the state of Maryland. So in Maryland, they have the health enterprise zones. So like Capitol Heights, which is on the border of DC, they have the health enterprise zone. Part of Baltimore has the health enterprise zone. I think that's what you're speaking to.
Mm-hmm.
I think that gets to your question.
All right.
Yeah.
Right, yeah, we're getting into that. So, sister over here.
My question is about criminalization of mental illness, and we know mass incarceration and mental illness and black men work together hand in hand. And do you know of anything happening to decriminalize mental illnesses within the black community?
Well, we talked a little bit about the impact of violence. So a lot of times people, I'm not a mental health professional, but I know that a lot of what the treatment occurs when people are in prison, or the identification, maybe not even the treatment, just the identification. But in terms of, it goes back to, I think Milo asked a question about this kind of overdiagnosis of schizophrenia and other serious mental illnesses compared to mood disorders in African American. I think that's something that we have to pay attention to symptomatology. We have to think about the context, the trauma that people are exposed to, violence in communities, financial hardship and things like that, and try to get people to talk about those things and seek out treatment in the correct ways rather than going the criminal route.
Yeah, so some of this too, there are, mobile crisis teams with police. Sometimes, in some places, police are trained to respond to mental health crises, to recognize them as mental health crises. Some places there are teams that respond where there's an issue of mental illness and try to do triage. And also there are there's been a wave of diversion projects where essentially you get sentenced to outpatient, you can go to jail, you can get outpatient treatment if you're convicted of, if you are convicted of a nonviolent crime. So those are some ways I think of trying to head off some of the, too many people in prison and jail.
And I think to add just to a quick point to that, that mental health advocates in the education realm have been working with educators around, sort of the over use of suspensions for black youth. And that's why it's important to have mental health professionals in schools, because we know then that youth who get identified early for, these suspensions and expulsions get into the juvenile justice when I think years ago, Linda Teplin did this work that kids who were in the juvenile detention settings in Chicago were, like a majority of them had mental health issues that were untreated. So I think, some of it in the education realm is about trying to curtail the suspensions and that sort of thing.
And also, I'm from Boston, and I've been in I'm a licensed clinical social worker. I've worked in this field for like 30 years. Within the last, I guess, 7 years or so, within the public sector insurance, there has been a child behavioral health initiative. So when kids are seen by their pediatricians, they are screened for mental health diagnoses. And if there's a concern about that, then they automatically refer it. So that's at the ones that, that early level. There are also different programs that are beginning to kind of sprout up as well to address some of those concerns. My second point, though, with respect to policy, I think, this notion of the Affordable Care Act of the patient home is a real opportunity to change the culture of that, getting to the authentic relationship among all the medical professionals, behavioral health professionals, and also so that a person can feel like, okay, they can go there, they're understood, they're embraced, by the people there. And I think from a policy perspective, that may be really a good place to begin to look at, maybe develop some competencies that would be helpful to promote the destigmatization. The last thing I want to say is that I'm also a member of the Boston branch of the NAACP. And one of their charges for the year, at least Michael Curry, who's the president's charge, is to highlight and to take a lead in some mental health issues. I'm a member of the health committee, and what we do is we do small health fairs, and I do a mental health table. Okay, and through games and quizzes and things like that, I engage people about myths, symptoms, things like that. They get a reward afterwards. But what's happened is that there's been some real fruitful discussion about, and very quickly, one woman, when many people left, one woman said to me, something happened to my son. He's married, they have a child, and everything was fine. There was an incident that occurred, and rightly so, he should be angry, but he's angry. I tried to talk to him. She said, is that something that I can get help with? And I'm like, yes. That's exactly what we're talking about. So what we're trying to do what I'm trying to do through the health center and the health committee is to use small forums to begin to engage people in a different way.
We have time for 2 more questions, brother, here with the neck.
Thank you. My name is Antoine Craigwell, and thanks to Terry for hosting this conference on Facebook. I'm the founder and president of Depressed Black Gay Men, which is an organization focusing specifically on depression in black gay men. And I've got 2 of my board members here who all came from New York for this. On Thursday, I was at Columbia University for a panel on LGBT health. It was an all-white panel, and they were talking mental health and diversity and cultural competency. So I asked the question, hopefully that by their next panel, they would have had some diversity or some black person or Latino on their panel. We're talking the black community here today. Is there anyone on this panel who may want to identify and say, I am gay or lesbian, because the gay and lesbian caucus in the black community is part of the human spectrum. And you know as well as I do that in the black community, black LGBT have been struggling for centuries, for years, and still do. One of the highest rates of mental illness, depression, panic attacks, and anxiety are among black LGBT. The highest rates of HIV infection among blacks, rising according to the CDC, among young black men between 13 and 29 is young black MSM. Second thing I want to find out is, you talk about cultural competency. What steps are being made in the black community to address LGBT or black mental health professionals being culturally competent to not just address black issues, but black LGBT issues? The third thing I want to ask is,
I feel part of the responsible that you're here, so sit your butt down.
hold on. Not yet. No, hold on. This is important.
Hurry up then.
This is also very important. Many of the mental health professionals we know in the black community have been trained according to a white, Freudian, Western European training module or paradigm. What is being done, and because there is research to show that there are a number, that the measurement tools used for black people is the same tools used for white people, and you cannot use the same tools. So my question from a policy or a next step, what is being done to address the measurement tools for black people and black LGBT, if you wanted to add in?
I don't know, but I think it's an excellent point. And what I do know is that it's a slow death when one can't be who they are. That's the other thing, too. So I'm glad you raised it. I just don't have an answer.
Other responses to the first part with the next steps and policy?
Go ahead. I was just going to say that with anything that is underrepresented or under discussed, it must be. It's a critical part of our
Right,
conversation.
exactly.
Absolutely, Antoine. And we have to keep pushing the issue. We just do. That's all I can
I agree with that
offer right
entirely.
now.
Yeah.
Other response? So we have, she had her hand up from the beginning.
She did have her hand up.
Yeah.
So I can't explain how elated I was when I found out that there's a focus on African American men, because they have a huge, especially older African American men, because they have a huge influence on the younger generation. I'm wondering if there is anything in the pipeline to counter some of the, what I view as negative advertising that trains African American men to leave behind the black female. And I'm sorry, say that again? What? So a lot of the time when I view advertising, I have 3 little cousins that I'm raising up as best as I can, helping, because it takes a village. And originally when they were first born, 2 and 3 years old, my hair is normally natural. I straightened it recently, but normally it's natural. They would run their hands through my hair all the time because they love black hair. But as they entered the school system, they've been reconditioned, and also as they started watching TV, they've been reconditioned to like straight hair or not black hair. So I'm wondering if there's anything in the pipeline to counter some of that advertising that trains African American men especially to leave behind the black woman, like to stop liking our hair or whatever have you. And also, I'm wondering, I feel that there should be some counter advertising, like maybe some advertising that trains our African American men to want to be teachers. And for the data that you're looking for, I just finished up a marketing research class. Sometimes you have to go to irregular places to find that data, like sub shops or barber shops, in order to get that data. And I really believe in your Just Smile or Say Hi campaign.
Any responses for the?
You said a lot, and I don't even know where to begin with. I just don't know where to begin. I personally don't. Yeah.
I think there have been like interventions that may not be framed in a mental health clinical sense that have looked at critically, media influences on sort of racial socialization, that sort of thing. I'm thinking about Rod Watt's work. He's done some work around that. So, I mean, I think that there could be a blending, if you will, of some of that work within a mental health context. But I think much of mental health treatment is so disorder specific, and usually trying to mitigate the symptoms related to a disorder. And so I don't know of any specific interventions that have a focus on the influence of media. Yeah, so I think you're getting at this issue of the continuum of mental health, if you will, from like illness to like, sort of positive mental health, if you will. And so, we need more prevention work, certainly.
One of the advertisements I'm speaking of, there's the Boston Metro runs an ad all the time. Do you hate yourself? Are the letters in the ad, and they constantly have a picture of a black man.
Really?
And yes, constantly. And
Who do you know who's behind it?
search them, so they said. Some of this training goes on. Like if I can get them to stop liking the African American female figures, then I can get them to stop liking themselves. So it's definitely a mental health impact.
As clearly evidenced by the extreme excitement with questions in the room, this conversation is only just begun. So unfortunately, we have to close the time, kind of move on to the next steps of the day. I want to give a couple of minutes